Hi, it's Dr. Centeno, and it's good to be back here in the United States. As some of you know, I was in Europe for 6 weeks on a sailing trip, and because I was on that time frame, it was generally easier to do a few of these Facebook Lives. At times convenient for Europe, but not convenient for the United States. So back in the United States now, and today we're going to talk about a topic I've covered before, but I think it's important to continue to beat this drum because I continue to see patients who are not understanding the connection between internal jugular vein compression and CCI and are getting kind of led down this path towards surgical correction of compression when many of them probably don't have symptoms that are being caused by internal jugular vein compression, and their internal jugular vein compression is probably just a normal variant that was picked up on an imaging study. So it's an important topic and one I'd like to sort of to cover again. In addition to that, we'll also go to questions after that. So I'll do a short lecture, if you will, and then questions. You can ask questions about this topic or really any topic at all. So no limit there. So let's go ahead. I am going to start that presentation. So we'll start with sharing the screen here. Looks like that's good. And then I'm going to go ahead and do this. Okay, so topic today is, do you need to get your internal jugular veins decompressed? And what I mean by that, when I say that, is surgically decompressed. So let's dive into that topic a little bit. Again, I've covered this in the past, but I want to cover it again because I'm seeing a lot of patients who are being led down this pathway towards surgical decompression of their internal jugular veins. And I think some of those have legitimate issues that require surgery, and some of them have issues that probably don't require surgery. We're probably looking at just normal variants on imaging, and that's causing these very invasive surgeries to get done. So, as you may know, there is a relationship between the internal jugular vein and C1 and C2. And so this is from a blog I did. Basically, here you see C1 and here you see C2. And you can see that the internal jugular vein passes right in front of the transverse process of C1 there. And in some patients, it also passes right in front of this C1, C2 joint. But as shown here in front of the transverse process of C1, so this is from the front, and that's what it looks like, and this is from the back, and that's what it looks like there. And compression of this internal jugular vein can be seen on imaging in some patients. And so this is the internal jugular vein here, and you can see it's wide up there and gets small, and that's the transverse process of C1 there. And on the other side is the styloid, and it can get compressed as it goes through there. Now, to look at this from above, this is a diagram I drew that's part of that same blog. It kind of shows you now from a top-down view that we have here the ring of C1 and these transverse processes of C1. And then we've got the internal jugular vein and then the styloid, or really stylohyoid ligament in most patients, right in front of that. So if these ligaments that hold C1 onto the dens are loose, or that hold C2 onto the head are loose, meaning the transverse ligaments are alar ligaments, you can get too much motion there, and you can get the internal jugular vein to get crunched. Now, this just shows in straight flexion extension. The blog also talks about rotation, etc. And that's the idea behind the link between craniocervical instability and internal jugular vein compression. Hence, it's plausible that in some patients, they have IJV compression due to instability. But having said that, does it mean that most of those patients need to get surgically decompressed? And does it even mean we know for sure that that internal jugular vein compression is causing their symptoms? And this is just basic logic, right? There's lots of different possibilities for things. One would be that we see internal jugular vein compression and it always causes symptoms. And that's really what a lot of the surgical mantra is around. And the other being that we need to be careful because there's patients out there with compressed internal jugular veins that have no symptoms. So we certainly wouldn't want to surgically decompress your internal jugular vein if it's not causing any problems, right? That's just exposing you to risk without any chance for upside. So we know that there is this overlap between patients who have CCI symptoms and patients who have internal jugular vein compression when we look. And the most reliable way to look is with a CT venogram. There are some providers that are trying to do it with ultrasound, and you can see somewhat with ultrasound. But really, if you're going to do this at a high level, you would want a CT or a CAT scan with a venogram. However, the causation, and this is kind of what the point is of this talk today, the causation between that internal jugular vein compression causing some of those CCI symptoms is much harder to diagnose. And the problem is, I can see that we're having patients get internal jugular vein decompression surgery, and they're getting no benefit at all. And they're probably getting no benefit at all because their compressed internal jugular vein was causing no symptoms. It was just a normal variant that the guy down the street may have had as well had we chosen to image his neck. So to make sure we're treating the right thing, again, we need to ask two critical questions. One is, what symptoms are most likely to come from internal jugular vein compression? And then the second is, how many normal patients are walking around out there with compressed internal jugular veins, but no symptoms? So what symptoms are most likely to come from IJV compression? And this is a word cloud based on a publication on symptoms for patients who had confirmed internal jugular vein compression, and the symptoms went away after the internal jugular vein was decompressed. So notice that the really big one here is insomnia. Now, the problem with that one is that's super nonspecific, right? Lots of things cause insomnia: too much caffeine, thinking about things at night, having an airway obstruction at night, etc. So that's a harder one. The ones I find interesting are head noises and tinnitus, because those are pretty specific. In particular, head noises is super specific because tinnitus has some overlap with CCI, right? There's patients with CCI who have tinnitus, and we treat their CCI and their tinnitus goes away. That's probably not related to internal jugular vein compression, but this is a little bit more specific for IJV, and head noises would be very specific for IJV. Headache, that's a hard one, right? Because lots of things cause headache. That's a list 20 items long, so that's non-specific. Hearing impairment, again, lots of things cause impaired hearing. Neck pain, same thing. So the ones that I'm really looking at here when I talk to a patient, when we're thinking about internal jugular vein compression, are head noise primarily, or head noises, and then secondarily tinnitus, understanding that tinnitus can be caused by other things having nothing to do with the internal jugular vein. So those are the ones that I'm really looking at to see whether or not there might be a connection: head noises and tinnitus. Now, let's answer that second question. How common is IJV compression in patients who don't have symptoms? And this is a critical question to ask. It is a critical question in all of medicine, because one of the problems with imaging studies is just because we can see that something looks abnormal on an imaging study does not mean that that's causing that person's problem. So, and we've known this ever since the early days of MRI, and it's become more and more clear that we need to be very careful with what we see on MRIs and CT scans and ultrasounds. So here we are. We know that based on a study of normal patients who happen to be getting their neck imaged for something else, that 1 in 3, up to 1 in 3 of those people, which is down here, right? 1 in 3 of those people had moderate stenosis either on the right or left, but no symptoms. And it went to 1 in 4 based on whether it was right or left. Even if we go to severe stenosis on one side, we're still talking 1 in 4 to 1 in 5 people with no symptoms had severe stenosis in their internal jugular vein. It's only when we get to severe bilateral stenosis, meaning stenosis on both sides, where the rate of finding that in a normal person goes down. So again, what that would mean is that if you've got severe bilateral stenosis on your CT venogram, then we're going to put a little bit more credibility in the idea that your symptoms could be caused by what we're seeing on the CT venogram. But if you've got moderate or severe stenosis on one side, since there's a lot of people walking around out there who have that and no symptoms at all, we need to be very careful about connecting those two dots, meaning that moderate or severe one-sided stenosis and the symptoms that you have. And again, the biggest problem with this is, how would your doctor know whether you're one of those 1 in 3 people with normal IJV stenosis and have symptoms due to something else, or are your symptoms due to the compression? And the answer is that there is no way to tell until we surgically decompress the IJV. And that's most commonly done through a procedure to cut the stylohyoid ligament. But that then further destabilizes the anterior neck. So we're in a little bit of a diagnostic pickle here. In order to see whether it's the internal jugular vein problem causing your issue, we need to cut an important ligament in a patient with upper neck instability that will make them more unstable. So as you can see, that's not a good place to be. Hence, be very careful with this idea that because you have IJV compression, you need to have it surgically decompressed. And that's because there's so many people walking around out there with IJV compression that don't know it, and they're totally normal and have no symptoms and no problems. So again, just be very, very careful with those concepts. So let's take some questions now. And we'll have to see how many people are on here, just because I haven't done this at this time frame in 6 weeks. So hopefully we have some questions. Great, we got a bunch. Okay, so let's see here. Regenix, been advanced by Fa Chun. Top fan, Fa Chun Duffy. If there is no recent trauma history, but the patient is still diagnosed with CCI, does that mean there must be a connective tissue issue as the cause? Yeah, so usually that's the cause, that there's some sort of connective tissue disorder, most common being hypermobile EDS. So that would usually be where we would look. Now, it's a little hard, right? Because we go through these incidents through our lives that may injure the upper neck. So I'm going to give an example from when I was on the boat. When I was on the boat, we got to climb up to the helm a little bit, and it was climbing up to the helm, and there's a low portal there that you go through. And I'm on this boat, it's a new boat. I stood up too straight rather than bending my head as I went through, and I, boom, nailed it really, really hard. I took a really hard whack on my head. Now, thankfully, I just got a scrape up here, and it wasn't all that bad. But how do I know if I develop CCI symptoms 6 months from now that it didn't happen, that the ligament laxity didn't happen at that time? And that's the hard part. So that's why we always try to look at people's backgrounds to see, is there something in their background of the last couple of years that could have loosened the ligaments and then with time led to symptoms? It's been advanced by Patricia Ford. When I think of how we hold our heads to use a cell phone or a laptop, I wonder if there will be a sharp rise in this condition, lead to greater awareness. What is happening in orthopedics neurology and preparing for a surge of patients with CCI symptoms? Are they being asked or seeking the education to refer a patient to someone with your expertise? Yeah, well, I think you bring up a great point, and that is that our posture, because of cell phone use and mostly this or this all day, is certainly putting more pressure on these ligaments and lots of other structures. So yes, we are seeing a rise in musculoskeletal neck and low back conditions from what it is we do now that we didn't do 15, 20 years ago. Now, is our healthcare system getting smarter about where to refer those patients? Not really. So that's one of those areas where I think social media can be a big benefit, is trying to make sure that these patients get aware, and so that they can serve as an advocate for themselves within that crazy medical care system. Diana, hi, Dr. Centeno. I tripped in August, slight stumble without brace on, bobblehead worsened, and now I have difficulty nodding. Yes. When I nod, my head detours in a zigzag. I'm unable to nod in a straight line. Seeing AO now. This was 12 degrees, now it's 6 degrees, but nodding is still an issue. It's worse with some adjustments. Is this AO joint or AA? Wondering if Chiro is the answer, or if it's you, unsure what nodding issue could be. Yeah, so Dana, that's a very good question, because it helps us get into the biomechanics a little bit, right? So when it comes to a nodding type motion, that's all 0-1. When it comes to rotation, 50% of your neck or your head on your neck rotation comes from 1-2. So the nodding thing would immediately get us to look at that 0-1 joint. So if it's not made better with AO or NUCA chiropractic, then that is something that we might need to see you for. It's possible you may have injured one of those joints, and you can't load it or can't load one part of it. So you tend to move away from that when you're in that nodding position. So it may be as simple as putting PRP to help heal that in the 0-1 joint, but it's definitely 0-1 based on what you're describing if we're going to try to focus on a joint as a cause. Diana, can AO Chiro fix an atlas that is shifted laterally, not just fix the rotation? Feel my AO joint is not fully in the joint. I have trouble with nodding. Yes. They should be able to get it back in. The big question, I think, would be whether it would be able to heal on its own. Regenics, been advanced by Harry Winston. Welcome back, Dr. Centeno. Any chance in your next selling expedition you would visit the Algo Cells Clinic in London, not to treat patients, maybe for a live event? You know, good question, Harry. As far as the good news is, I think this next time we will go through London. This time we had to go through Paris in order to pick up the boat. But I'd prefer to go through London than go through Paris. So we will be in London. As far as doing a live in Algo Cells, I'll have to ask those guys to see if they're okay with that. But, you know, listen, I'm certainly open for something like that. And we will probably go through London next time in May, just because we won't need to go through France in order to pick up the boat. Diana, is sudden pressure in ears while being upright another symptom of IJV compression? How do patients describe head noises? What sounds they describe? Swirling, swishing. Yeah, normally with head noises, patients are describing a swishing sensation within their head. Sudden pressure in ears is not one that's more commonly seen with IJV. And that can be seen with lots of different problems. That can be related to the little nerves that run the little muscles inside the ear. That can be related to the temporoauricular nerve. That can be related to problems with the sternocleidomastoid, etc. Robert, this is exactly what I try to relate to patients, that many syndromes overlap symptoms. Yeah, I agree with you, Robert. We see these overlaps happen, and it's a hard one for doctors, and it's certainly a hard one for patients. But we need to focus on the symptoms that are more specific to the disorder, and not the symptoms that are shared by many disorders. So here's another example for you. So when it comes to CCI, some of the symptoms and signs that are specific to CCI would be, headache, imbalance / dizziness, are very common in CCI patients, but they're not super specific for that problem. Now, you can dial that further in by saying that the headache, dizziness, and other symptoms get worse when the neck is moved, and get better when a cervical collar is on. So now we're narrowing that in a little bit. And you can also do things like, physical therapy, which should make it better, generally flares it up. So you can add those little things in order to further hone down the diagnosis and to put some things around the diagnosis so you can increase accuracy. Or things like, if we treat the upper neck, the person gets better on a temporary basis. So I would agree with you 100%. We want to make sure that we don't take those super general descriptions like headache. Headache happens due to 20 different conditions. So it's super nonspecific. We've got to put more things around that headache in order to dial it into CCI or IJV or whatever it is we're trying to get to. Actually, are you able to be more specific? What do you mean by head noises? Yeah, Rachel, I think it's different for different patients, but the most common thing I would hear described would be a swooshing sensation in the head. So I think that's the most common thing that's often described by patients. Sharon, higher Centeno, interesting topic. I have a very good quality MRV. Would this be sufficient, or would you recommend a CTV as well? Yeah, Sharon, the biggest problem with MRI arteriograms or venograms is it takes a long time to get the signal, much longer than a CT scan. So sometimes they tend to miss things because you don't have the person in the right position in order to get or demonstrate the compression. But listen, if an MR venogram shows compression, then obviously we got to go then to the next step of saying, is that compression causing your symptoms? And if it was negative, then we would move on to a CTV, which would be more sensitive in finding compression if it were there. Robert, why do most vascular surgeons who see the hourglass shape of the IJV not concerned, even though it's clearly crimped around C1 transverse? Robert, I think for the very reason I'm bringing up in this particular lecture, and that is that I think most of them recognize that at the end of the day, they see a lot of asymptomatic compression of the internal jugular vein, right? Realize that they're seeing lots of different types of patients. They're seeing people with external carotid artery problems. They're seeing patients with blowouts of various arteries in the head and neck and brain. And on those studies, they're also seeing a lot of internal jugular vein compression in patients that don't complain of anything related to internal jugular vein compression. So I think that's why you're going to see those guys be a lot more conservative about making these calls. And just like I said, it's really only when you get to severe bilateral compression where you start to get concerned that you probably, more likely than not, have symptomatic internal jugular vein compression. But I think it's because they see a lot of asymptomatic compression out there. Liam, do alar ligaments prevent C1 and C2 from moving too far forward? Which ligaments are responsible for preventing C1 and C2 from moving forward? Generally, the transverse ligament does most of that work, but the alar ligaments in some patients are tilted back, and everyone's got slightly different anatomy, but if they're tilted back, then they're also going to help participate in that. But realize that there are anatomical differences between patients as to where those alar ligaments go, or where they start and where they end up, and their direction. So that's why it's not hard and fast. But if you had to make a hard and fast rule that was applicable to almost everyone, it would be the transverse ligament reduces movement between C1 and C2. And then the alar ligaments would be secondary. Now realize it's not only the direction the alar ligaments go, but they provide compressive force between C2 and the skull. And so by providing that compressive force, they're also allowing the joints to provide stability. So they're sort of the first level of knowledge, and that is, where do these ligaments go and what do they do? Then the second layer, deep from that, would be that these ligaments also connect and compress things that allow the joints to provide more stability. Sharon, can the IJVs be compressed by the anterior muscles, digastric, or compressed by a nerve? How can this be assessed, and how would this mechanism work in relation to CCI? So can the IJVs be compressed by anterior muscles? I would say that that's less likely unless there's some sort of anatomical variant where the IJVs happen to pass through that muscle, which is not something that generally happens, or compressed by a nerve. Again, less likely, right? Because nerves can hypertrophy, but unless there was some sort of specific ganglion abnormal swelling in that nerve that made it hard, because nerves have a very soft consistency, we wouldn't normally have a situation where a nerve was compressing a large vein like the internal jugular vein. You have to realize the internal jugular vein is one of the largest veins in the head and neck. So it's fairly big and beefy. So it's not going to be compressed by much smaller nerves unless there's something really going on with that nerve. Sharon, can even a slight reverse curve cause IJV compression, and how? Yes, I think what a reverse curve does is it ends up bringing those things closer together in more approximation. And when you have a normal curve, it provides some distance at the top and bottom from the vessels that are running in front. An abnormal curve would bring the top in particular, or straightened curve, towards that internal jugular vein. Rachel, I just want to comment that CCI is not limited to the hypermobile type EDS. I have CDDS confirmed via genetic testing and have CCI, IJV compression, etc. No, Rachel, I didn't mean to state that it was. Certainly, if you've got any type of EDS, then that's something that's going to be in your diagnostic list, right? So everything or every disease we have increases our risk for certain things. So it moves those certain things to the top to be crossed off or circled as caused by or related to that problem. And so EDS would fit in that, not just HEDS. And realize that when I say EDS or when I say HEDS, we're talking about a collection of lots of different genetic diseases that fall in different boxes. So, for instance, my niece has a collagen 10 disorder. It's an extremely rare cause of hypermobility. Is it EDS? It's not classically described as HEDS, but it definitely looks an awful lot like HEDS. So we're talking about boxes in which lots of different genetic variants live. Regenix, been advanced by Shari Scott. I was told I have internal jugular vein compression based on an MRI, but I also have been diagnosed with CCI based on a DMX. Is it possible to have both, or is it unlikely enough to treat the CCI first? Is much rather the answer to my issues than a surgical procedure. Yeah, so that's usually the approach. Yes, the two can coexist, meaning the instability, as I was showing in the lecture before, can cause compression of the internal jugular vein, and that then can lead to the fix being get rid of the instability, right? You always want to do the least invasive thing that's the most likely to work. So the thing that you would want to do or want to try first would be getting rid of the instability and see if the internal jugular vein issues go away. Dr. Centeno, thanks so much for discussing these topics. I'm going to see you for our first PICL procedure November 30th. I'm just preparing my nutrition and supplements beforehand, and I've heard of a few of your patients on the Facebook page. They're using healing peptides. Do you recommend those? And if so, should I start taking them for the procedure as well as after? Also, do you recommend starting the clock exercise before the procedure as well as after? Yeah, so Bethany, as far as peptides go, it's the Wild West right now. And what I mean by that is I would, number one, have serious concerns as to whether or not any peptides are being sold on social media that are legitimate peptides as advertised. So, for instance, I just saw last night on Facebook a bunch of ads for BPC 157 or the Wolverine peptide. I don't see any independent testing out of that company selling that stuff that shows that those vials actually contain BPC 157. We've tested this with other things like companies that were selling transforming growth factor beta and found that their vials didn't contain enough transforming growth factor beta to make that claim. So that's the first thing. And then the second thing would be whether or not we have any evidence that taking these peptides will do anything for your ligaments at all, because there's no human level data on patients taking this and then us looking at the quality of their ligaments. So on peptides, I'd probably stay away at this point. And then when it comes to the clock exercises, you really don't want to start that until you're given the green light by your treating physician, and that's normally after the procedure. One and only one, avoid looking up or using my neck to look side to side. I had a DVT in the jugular 15 years ago. Okay, noted. Munit, do you recommend gyrostim therapy? And if you do, can you comment on when to initiate the therapy? And also, is it very expensive per session? Would you know how many sessions one needs for seeing benefits? You know, Munit, I think gyrostim is something that we do like. We've had some patients who have sworn by it. I would say that it's a higher level thing. And we've got a patient that you can reach out to who's actually been interviewed here, Pam. Her first name is Pam. So if you contact Carla, my assistant, and she can put you in touch with Pam, and Pam can give you her experience with gyrostim. But I wouldn't recommend it right off the bat. I'd only recommend it if you could do something like those clock exercises competently and you feel like you need additional strengthening. Robert, do you see a different value between CTV versus MRV? Do you normally require these for C012 posterior injections? So, yeah, I think CTV is more likely to be accurate versus MRV, and that's just because it takes longer to get an MRV signal. So you really can't do any type of maneuvers or movements with that type of imaging. But we don't usually require those prior to posterior injections. My arm is always purple, and I carry it with the other arm sometimes. Maybe the vein is compressed. Well, that's definitely something you'd want to get checked out by a qualified physician to make sure there's no DVT in here that might be causing your arm to go purple, one and only one. Sharon, I get treated by an AO doctor, but he's against CBP and pushing the neck into a good curve. Yeah, they should be complementary. That's something you may need to discuss more with a local CBP doctor, maybe go see someone for evaluation, get that doctor to reach out to the AO doctor and get them communicating. Diana, thank you for your answer to my question. With the nodding issue, could it be that the occipital condyles are not aligned anymore, or is that very dangerous considered a dislocation? Trying to understand the mechanics of the issue. Yeah, Diana, well, if they're dislocated, meaning they have jumped out of their joints, that's something we could see on an X-ray or an MRI. I think it's more likely, however, that certain parts of the joint have become painful and your body is literally trying to avoid that contact pressure. So it's changing the way you nod to get away from that pain. That's probably more likely than them being frankly dislocated. Robert, can the soft tissue in the occiput, PAOM, RCPM, create compression of the vertebral artery? Yeah, it's a good question. The rectus capitis posterior minor really isn't in a position to do that. There are other muscles that may, but I think more likely what we tend to see there, rather than frank compression of the vertebral artery, is that we will see that excessive motion between C1 and C2 can cause problems there. And that's because the vertebral artery snakes through C1, C2. Sharon, I'm getting treated by an AO doctor, but he is again, yeah, got that one. What are your thoughts about this after regenerative medicine? Yeah, Sharon, I think the best thing to do is to get the AO doctor and the CBP doctor talking, or another option would simply be, if you're seeing one of us, we can certainly reach out to the AO doctor and say, this is what we'd like to happen and why. Rachel Riggs, is CTV invasive? It does involve injecting a dye in IV. So not really invasive in the way you're thinking. Diane, I'm seeing Dr. Rosa before seeing you in December. I'm wondering if a DMX is still needed if you have his images. I do have the lateral overhang seen on my other static x-ray, but I was rotated to the right side, was not seen. I'm terrified of stress x-rays, DMX, because my last x-ray is in July, and I'm still recovering from that. Also had a recent supine 3T. So yeah, Diana, I think that the first thing to do would be, let's look at Rosa's images and to see if we can get to the diagnosis. So as I always say, different types of imaging have different sensitivities, and sensitivity means the likelihood that we're going to be able to get to the diagnosis with that type of imaging. So for us, DMX is the highest likelihood to get to a CCI diagnosis. Then comes movement-based images like the ones we're talking about, or MRIs, upright MRIs. So let's look at those images and see whether or not we can get to the CCI diagnosis. And if we can, we don't need the DMX study. If we can't, then we may need the DMX study, but definitely reasonable to start with Dr. Rosa's images and see what we can see. Personal noise experience. I get a whooshing noise with the heart rate in right ear as well as pulsation, yet this is triggered by looking or leaning down or getting up from squatting. I can see my IJV is crimped. Yeah, so again, we've got now a symptom that is more commonly related to internal jugular vein compression. And then we need to get into how much compression we have. So if it's severe bilateral, again, we're going to push more in that direction. If it's moderate unilateral, we're going to be a little concerned about tying those two things together because there's a 1 in 3 chance that it's a normal variant. So that's all part of that diagnostic process. Sharon, do you ever see IJVs being compressed at the level of C1 and massively decreased flow further down? We certainly see IJVs getting compressed at C1. As far as massively decreased flow further down, normally you don't see that. Normally you'll see the hourglass type shape that was described before, where the vein goes from big to small to big again. So that's more commonly what you see. Tom, could you please do a video on loss of curve in cervical spine? I've had symptomatic CCI and my neck curves backwards, and I'm not sure how big of a deal it is and what to do about it. Sure, Tom, we'll definitely consider doing that. The big concern is when you have loss of curve, you're putting weight on those upper cervical ligaments. And so getting that curve back helps to take the excess weight off of those ligaments. So that's how the two are connected. Diana, I bought a cervical spine pillow recommended by Dr. Rosa, my local AO. The pillow, however, gives me headaches and nausea. Should I keep using it? Yeah, so Diana, I mean, that's one of those things that's super duper personal when it comes to which pillows work for which patients. So I always tell patients that the best thing to do is to buy some inexpensive ones off of Amazon, try a few different ones, or even go into a store that has them and try a few different ones and see which one fits the best. Because my concern is that I've seen a pillow that should work well for someone, for whatever reason, not. So that's just super different between patients. So I always tell patients definitely shop around, try to get one. Same thing with cervical collars, right? Some cervical collars are great. Others tend to put someone in a bad position and cause more symptoms than not. So same thing, lots of cheap cervical collars these days on Amazon. Buy a few of them, try a few of them out, maybe cut one up, take a little out here, etc., and try to find one that fits you. Sharon, how do you know whether IJV compression is structural anatomical problem or caused by CCI? We don't really, Sharon, unless we can see the IJV compression happening as the bones move, which is going to be less likely to capture. But it is easier to try to tighten down the upper cervical ligaments and see if the symptoms go away than it is to cut the stylohyoid ligament, which is an invasive surgery, more invasive than the PICL, which destabilizes the neck to see if the symptoms go away. Diana, if a patient has had multiple events of head trauma without symptoms until a recent accident, doesn't make it less likely to have EDS. My initial thought was that EDS patients might experience symptoms with even one whiplash type incident. Diana, we do see that EDS patients are more fragile, if you will, and it takes less force to cause CCI, which makes sense. Sharon, can you get regenerative medicine if systemic inflammation is causing CCI? Sharon, we don't have any evidence that systemic inflammation is causing CCI, so I wouldn't put any credence in that diagnostic connection. I know that's a common integrative medicine concept, that somehow systemic inflammation leads to ligament laxity. I don't see any evidence to support that, and certainly none to support that it causes CCI. Fatchin, a CCI patient, took a PRP at C1C2. The doc told her that it might take maybe 4 to 6 weeks rather than 46 weeks to see results for some patients. Patient had a crash after 5 weeks from procedure. The doctor said the crash could be because other unstable areas got overworked since the area injected could not help them for some time. What do you think of this and the timing? Well, 4 to 6 weeks, I think, is reasonable to see improvements. If you mean they had not a physical crash, but a symptom crash after 5 weeks from the procedure, I'd need to know more about what was going on with the patient. I'd need to know whether or not there was an actual intra-articular injection at C1C2 using fluoroscopy and contrast confirmation, or a fake C1C2 facet injection like a lot of clinics do. So certainly not enough info there for me to answer that one accurately. Robert, follow-up on CTAV. Are there cases where those with new growth of arteries or veins cause a problem with injecting? Could the needle puncture through these be of concern? My doctor saw a faint collateral on the way left and decided not to inject my left C0C1. Shouldn't be an issue at all, meaning the internal jugular vein would be nowhere near the entry point. If you're talking about a collateral related to the vertebral artery, that would be interesting. But your doctor may have chosen not to do C0C1 just based on lack of experience with that procedure. I think I've talked about this a lot, and we have lots and lots of patients out there needing these injections, but very few physicians with a lot of experience in performing these injections. So there may be a mismatch there. Sharon, if needed, after how many days or weeks would you recommend to get adjusted by the AO doctor after regenerative medicine? we're fine with it being days later, not a problem at all. Diana, is it possible to see an AO dislocation on a 3T MRI? My x-rays were just before this issue started, unfortunately. Yeah, so it certainly is possible to see an AO dislocation on a 3T MRI for sure. Edward Chen, what percent of PICL patients show improvement by the 4-month follow-up? Yeah, we're looking at that 7 in 10 response rate by that time. Sharon, I know vascular compression can cause pressure in the head. Can nerves also cause sensation of head pressure? They certainly can, yes. Sharon, you say it's not common to have decreased flow of the IJV further down. Is it even CCI related? Sharon, I'd need to see specifically what you're talking about, but normally it's that hourglass shape. Now, if there's a smaller vein further down, then that may be due to other problems, i.e. there may be a congenitally small internal jugular vein. Robin, I hope your vacation was great. Dr. C. Regenix Florida is treating my shoulder slap tear soon. No pain in shoulder, but I'm comfortably laying on my left side. Great, Robin. Yes, it was a very nice vacation. Although I'm starting to peter out here. I'm getting into late time frame for what I was used to just yesterday and the day before. Eric, how about taking collagen supplements with other vitamins? Sure. Yeah, Eric, that sounds just fine. Sharon, sorry for my question. Systemic inflammation, so it's safe to get regen if you have RA. Further can worsen inflammation, but no, this is true. So if you've got rheumatoid arthritis, we're talking now about a completely different category. So when it comes to rheumatoid arthritis, we know that the process can break down upper cervical ligaments. So if you've got an active rheumatoid arthritis for which you're seeing a rheumatologist and getting treated with biologics, then that's definitely a conversation to have as to whether or not that would be a safe thing to do with a PICL procedure. That being very different than the alternative medicine / integrative definition of someone with, let's say, a positive rheumatoid factor. So very different things there, and I want to separate those things out. The rheumatology definition of rheumatoid arthritis and the alternative medicine definition. Rachel, both glucosamine and glycine seems to have helped me a bit. Great to hear, Rachel. Fachin, with PICL or posterior PRP, do the needle touch the ligament or inject around the area? I've heard the term facet capsule mentioned. Is it where the injection happens? So when it comes to PICL, you're injecting inside the alar or transverse ligament. And then when it comes to posterior PRP, again, the goal is to inject into the ligaments. When it comes to facet capsule, all facet capsule means is that you're seeing a doctor who doesn't have the skill level to inject inside the joint. So they call it a facet capsular injection. So if you've seen the term facet capsule, you're seeing a doctor that doesn't have the expertise to do upper neck injections. Sharon, my biggest fear, do you ever see head pressure increasing temporarily after posteriors? Not something we see commonly after posterior injections, although certainly possible. Diana, does any Regenix clinic do posterior dextrose prolotherapy below C2? I found dextrose helped me so far. Do people who do well with dextrose do well with PRP typically? Not any Regenix clinic, but a lot of them would do posterior injections below C2, those that do spine work. And yes, a good response to dextrose prolotherapy tends to indicate a good response to PRP. Bethany, can severe pressure headaches be caused only by CCI without IJV compression? Sure. Yeah, we see that all the time. Roger, I'm glad you were able to do some sailing and that you have some greater insight about the physical challenges for that environment. I regret going out in a sailboat in the month after my 2014 car crash, but I was totally unaware of the torn CCJ ligaments. I wear my Aspen collar when it's rough on the boat, when I hoist the sails and lift the anchor, fair winds and following seas. So thanks, Roger. Listen, sailing is, as you know, a physical thing. And one of the reasons why we decided to get it in now was our kids are old enough to be in college, not yet old enough for us to think about grandchildren. And yet, as far as waiting until I'm fully retired and not working at all, it's pretty physical, as you know. So we wanted to make sure we were still young enough to do something like this and enjoy it without getting into that age where it becomes a burden to do the very physical things you need to do to be able to sail well. So thank you. Okay, guys. So it looks like we're starting to peter out on questions, and I'm certainly petering out on the jet lag part because it's one of those things you don't even want to think about, right? When you're here, you don't want to think about what the time is there. When you're there, you don't want to think about what the time is where you come from. So I'll take a few more questions, and then I'll probably allow you guys to enjoy your Halloween. So let me take a few more here. Christine, have you treated many patients who were bedridden? I'm struggling with heavy head, dizzy, so much pressure in the head. We have treated patients who are bedridden, but what I always tell people, Christine, or patients is that the deeper the hole, the harder it is to climb out of. And what I mean by that is that the more disability the patient has, and the longer that disability has been going on, the harder it is to get you out of that hole back to being fully functional. So if you've been bedridden for years, can we help those types of patients? Yes, we have helped those types of patients. Is it something that's harder to do than treating someone who is not bedridden? Yes, it is harder to do. Fei-Chen, how do you determine which C levels ligaments need to be injected with posterior PRP, for instance, 0, 1, 1, 2? Is it based on the result of DMX? No, Fei-Chen, it's a combination of the DMX, the other imaging, and a good hands-on physical exam and symptoms. So all four of those things are used to try to figure out which levels. Diana, happy to be back. I'm glad I'm on the same time frame as you guys now. As you know, I did a few of these Facebook Lives, but we were on different time frames. So all the European patients, it was great because all of a sudden I appeared on their Facebook at not 3 a.m. or 2 a.m. or midnight, but at 2 p.m. But now all you U.S. guys can benefit. Burgate, Laura, is there anyone you could recommend in Europe for those who can't fly? Not anyone right now that does this kind of work. So regrettably not. Yes, Robert, I certainly will rest up, hopefully get a good night's sleep tonight. Last night was a little hit or miss, but hopefully tonight I'll be tired enough to get a nice, good, solid sleep. Christine, okay, thanks. I've been bedridden maybe 70% of the day in 5 years, but young, I hope it's a good thing. Yeah, Christine. So we've certainly helped patients like that, but just realize that the hole there is pretty deep to climb out of. Well, guys, I'm going to start signing off. I will get back to doing this twice a week or as close to twice a week as I can get. Normally, that's going to stick to Monday at 1 p.m. Mountain, which is 3 p.m. Eastern or noon Pacific, and the same time on Fridays. Now, sometimes I can't do 2 in a week. There's too much going on, but I'll try to do 2 a week and try to pick a topic to do. And goal is just to make sure, again, that everyone gets educated, everyone gets their questions answered, because as you know, there's just lots of information floating around out there, and social media is a two-edged sword. On the one hand, it can be fantastic because it gives you insights that you can't get elsewhere. On the other hand, it can also be hard because the information comes at you like a fire hose. So the goal is to try to sift through that information, or to have me help you sift through that information. So thanks so much for your time. I'll be back on Friday at 1 Mountain Time, 3 p.m. Eastern, noon on the West Coast. Thank you so much.